Hi, everybody. We are back again. And today we're going to talk about electrocardiography or EKGs. This is a skill and a procedure that medical assistants learn. We do these in various clinics, doctor's offices, cardiology, family medicine, primary care, urgent care, sometimes pediatrics. We do them in a variety of places. So it's a really good skill to have, a really good thing to know. Not to mention, for those of you who have not already taken a national exam or are getting prepared to, there are many questions about EKGs on your national exam. This is a good video. If you haven't already watched my video on the cardiovascular system, it's not a bad pairing with that video because once you learn about the heart, the EKGs make a lot of sense. And once you learn about EKGs, the heart makes a lot of sense and vice versa. So let's go ahead and take a look here. So electrocardiography, abbreviated to ECG or EKG, either is correct, measures the electrical activity of the heart. So I've had patients before when I'm getting ready to hook them up to an EKG machine. If they've never had one and they're not aware of what they are about, will say, "Oh, is this going to shock me?" And I always kind of just giggle and say, no, you're going to shock it, which is kind of true. The machine is actually recording the electricity that's coming off of the heart. Now, that is minor compared to, the outside of our body. So there's an amplifier inside of the EKG machine. It helps to kind of amplify that electricity so it can be turned into actual visual, tracings. But that's what it's measuring. There are two separate poles, negative and positive, just like in a battery, right? So it is measuring polarity. Now, this is where it gets a little confusing. So I try to remember it. I try to, think up ways to remember this. So depolarization is what is occurring when the heart muscle is contracting. Repolarization is what's occurring when the heart muscle is relaxing. Okay. Um, for some reason, that always seemed backwards to me because whenever I hear something that starts with DE, to me, it kind of is like it's not doing something, but in this case, it is. So, what I always have tried to remember is that repolarization equals relaxing. And then depolarization is when the contraction actually happens or the work. Um, one complete heartbeat is what we call the cardiac cycle. So that boom boom, or in books you'll see lub dub, right? That is one complete heartbeat. That's the cardiac cycle. Here's what the cardiac cycle kind of looks like. So right here you have the SA node, this little guy up here situated in the top of the right atria. Um, the SA node or the sinoatrial node is what everyone refers to as the pacemaker of the heart. Okay. And I say pacemaker. Okay. Because I'm sure everyone has heard of pacemakers being implanted into people. That is generally when the electrical activity or the conduction is having a hard time kind of conducting, so to speak. Because the SA node is what kicks everything off, anything that would result afterwards gets thrown off if there's something wrong with the SA node. So in that case, sometimes a cardiologist will recommend that someone have a pacemaker implanted, which is basically just a pseudo or fake SA node, basically. So it starts with the SA node. That triggers that first impulse of electricity. It travels across the wall of the atrium and into the pathways to the atrioventricular node, which is this guy right here, where it takes kind of just a little pause, okay? And then it travels down into the pathway here through this septum. This is the ventricular septum, okay? And down into what they call the bundle of His, which is right here, okay? And or the AV bundle, you can call it either. That gets then divided between two bundle branches, the left and the right bundle branches, which are these guys right here. That impulse then continues down, travels down to the apex of the heart, which the apex is always the pointy end of the heart, and then goes to the right and to the left. Okay. Notice my cursor here went to the right and to the left, and you're going, she's backwards. Oh my God. No, I am not backwards because remember, when we are looking at a patient and we are discussing a patient, we're describing anything on a patient, it's their right and left, which is opposite of what we're seeing. So this is the right, this is the left. Okay. So it goes off to the right, off to the left, and then into what are called Purkinje fibers. And the Purkinje fibers then carry that impulse through the right and left ventricles, causing them to contract. So all of this is all about contraction, right? We start out up here, down here, a slight little pause so everything can catch up. Down we go into the bundle of His, to the right and to the left, bundle branches, out through the Purkinje fibers, and then that causes contraction down here. So that is the cardiac cycle. And again, that is one heartbeat, lub dub, boom boom, however you want to talk about it or make the sound, okay? Okay, so here's what a basic EKG looks like, okay? A basic EKG will record waves, or at least be represented in a recording of waves known as deflections, okay? So here is what basically that looks like. And I'm sure you've seen an actual EKG being done. Maybe you've had one. You see this drawing on things that represent heartbeats, right? Okay. So what's happening here is we divide up these deflections, or what we call waves, okay? Right here, we have what's known as the P wave. And yes, it's in order alphabetically, P, Q, R, S, T, okay? So the P wave is first. What's happening that the P wave is representing is when that sinoatrial node, or the SA node impulse, happens, and the atria, the top two chambers of the heart, again, if you haven't watched my cardiac or cardiovascular system video, I would recommend you do that. So when the atria, the two top chambers of the heart, contract, that's what's being represented by this P wave. Okay. Then we have next right here the Q wave. Okay. And then R, S, and T. Now, the QRST we call a complex because there are things occurring within that time frame that are kind of happening at the same time. So since the P wave is representing the contraction of the atria, the two top chambers of the heart, this QRS complex here, so QRS all together, are representing the depolarization and ventricular contraction. So after, because we know lub dub, boom boom, right? The first boom is the atria contracting. The second boom is the ventricles contracting. So in between where the contraction of the ventricles, or I'm sorry, the atria stop and they start to relax. And when the ventricles contract, we have this area here. So ventricular contraction is happening here. Then the ventricles relax, which is this little space in between the S and the T wave, which they call a segment, the ST segment. Okay. And then the ventricles have to repolarize or relax and kind of recover themselves to start over again. And that is what's being represented by the T wave. So you have P wave, atrial contraction, relaxation, ventricular contraction, relaxation, recovery of the ventricles, and then we start all over again. Now you'll notice here on this particular diagram, they talk about a U wave. Some people will throw a U wave. You'll see a U wave. It doesn't happen often. I think in my entire 26 years in this business, I think I've seen it like twice. So it's not common, but they do throw that in there. They're not quite sure what causes the U wave in some people. It could just be an extra little representation of relaxation, repolarization, who knows? But it's generally not there. Okay. So that is what one heartbeat looks like. Okay. Now, here is a little bit better representation of what is going on each wave and each segment and each interval. If you want to, I would highly recommend screenshotting this as well as the last one. But again, here we have, and here's depolarization represented in this yellow color, repolarization represented in the red color. So contraction versus relaxation. And then the highlighted wave or segment or interval is what is happening at that time. So SA node kicks off, impulse causes the atria to contract, P wave. Atrial depolarization finishes. The impulse is delayed slightly at that AV node, as I had mentioned. That's what causes this interval right here in between the P and the Q. Then ventricular depolarization starts, causing this QRS complex to happen. That is also occurring while atrial repolarization is occurring because the atria just contracted, they have to relax. Those are happening simultaneously. Then ventricular depolarization is complete. So we go into a baseline here. Anytime you see these baselines, these flat lines, it basically just means that the heart's not doing anything. Because if the heart's not doing anything, there's nothing to cause a deflection. So this is once the contraction ends in the ventricles, kind of does a quick little relaxation of, nothingness basically. Then the repolarization begins, that causes this T wave, and then that finishes flat line onto the next. So it's a really good kind of representation of each of those things. And as I always say, I highly recommend that you screenshot these. All right, if you have not already, and you're enjoying what I'm doing, and hopefully I'm helping you out, I really do enjoy doing this for you. Please hit that like and subscribe, and it really goes a long way for me. I appreciate it greatly, and helps me to continue doing what I'm doing. Okay, so let's talk about now that we kind of know the basics of what an EKG is and what everything represents. Let's talk about like all the stuff we need, okay? So here are some of the supplies that you will need when doing an EKG. So here's the sheet of them, and then here's the individual. These are the electrodes, and we'll talk about electrodes here in a minute. But these are I call them the stickies. Some people call them stickers. But these are the electrodes that actually get stuck onto the patient's body. These are the lead wires. Okay. And no, this would not work with it in its current form. But these are the lead wires that are connected to then these that plug into the machine. And this is an alligator clip. The alligator clip is what actually goes onto, there's a little hole right back here that slides right onto the little metal prong on the lead wires. And this is what allows you to clip this on to this portion of the electrode. These are great. These are interchangeable, fairly inexpensive. So any place I've ever worked at has done EKGs. We always had a backup set of alligator clips just in case any of them broke or anything. They don't last forever, unfortunately. So those are kind of all. And then, of course, the machine. You need the machine. EKG machines all look a little different. They're all different shapes, different sizes. The newer ones are, far fancier than the older ones. They all come on a little cart usually. There's little tiny ones you can actually carry around, which are kind of nice. But this is your kind of typical cart, and the carts are great because you can put all your supplies in there, all your electrodes, and I always liked to carry some alcohol prep pads on there. So I have to worry about getting them in the room, and that way I could clean off my patient's skin if it was very oily or had a lot of lotions or anything on it. Um, Also, they're great for cleaning off the alligator clips if any of the adhesive from the electrodes gets on the alligator clips. So that's good to have too. This is the cart of dreams. This cart has a little arm right here that actually holds the I call it the harness. I don't know if that's a proper term for it. But it's the part right here that all of the lead wires come out of. And this is beautiful because this arm here actually is flexible. So you can literally just bend it down over the patient and all the lead wires will just hang so they don't get tangled up. Otherwise, if you don't have one of these, you have to lay this onto your patient or onto the exam table next to them. And then the wires get all weird and tangled. It's like Christmas lights and it's not cool. So these are great. If you're fortunate enough to work somewhere that has one of these, you are lucky. This is what the general EKG machine screen will look like. Again, they're each a little different depending on the manufacturer. But this is what actually gets printed out if you print out a paper. Some of these will allow you to just send them directly through an EHR so the physician or the provider can take a look at it. But if you notice, there's these buttons down here where you can freeze it, you can display it, you can run a report on it, you can print it. You'd put your patient's name and gender and age and their patient ID if you have one of those over in here. You just enter that in. Notice there's a keyboard here. And then it shows you the tracing. We'll talk a little bit about troubleshooting and what things are supposed to look like here in a minute. But you have here Roman numerals 1, 2, and 3. These are your bipolar leads. Okay, that's what they're called, bipolar leads. AVR, AVL, AVF. These are augmented leads. I'll tell you what all this means here in a minute. And then you have V1 through V6. These are your precordial or your chest leads. And then this guy down here is just a running recording of this lead, number 2, right here. This is what we always call or refer to as a rhythm strip. Okay. So basically what all of these are, and we're going to get into the whole lead thing here in a minute, but basically what all of these are literally just pictures or snapshots 10-second little tiny snapshots of the heart and its activity at various angles. Okay, so these bipolar leads show various angles from this arm to this arm, so on and so forth. Um, these do the same thing, and then these are showing the angles on the chest itself because these are the lead wires that get attached to the chest itself that we're going to talk about here in a minute. And then why bipolar lead 2 is down here is this is the movie. If these are the snapshots, this is the movie. Okay, if that makes any sense. Or in YouTube speak, these are the thumbnails, this is the video. Okay. All right. So when performing an EKG, the MA, are in charge of preparing the room, preparing the equipment. We always want to make sure that our EKG machine is in good working order. It's been plugged in. Yes, most EKG machines are rechargeable. So if they're plugged into the wall, you can unplug them, and for a time, just like your phone, just like everything else, they will stay working. We need to prepare the patient. And in preparing the patient, that means that they have to undress from their waist up. They have to put on a gown that we provide to them, and we let them know to make sure to have that open in the front so we have access to their chest. Your office may do it differently, which, as I've always said, go with the flow. But 9 times out of 10, you have them open it in the front. Um, Make sure that their legs and their arms are free as well. So arms will be if they're undressed, but their legs, they don't have to take their pants off or anything like that, but you do need to be able to get to their calves. And I generally will have the patient take their shoes off as well, just because sometimes some shoes have metal in them, which can be a problem. Um, so I get them all prepared, step out of the room, let them, get changed. And then when we come back in, you, of course, lie them down, um, pull if you're on a regular exam table, pull the extender out for their legs, make sure they're comfortable. Some people, exam tables are not the most comfortable. So some people will have kind of lower back issues or anything. It's perfectly acceptable for them to put their legs up, or you can even stick a pillow underneath their knees. It's really helpful for their back. Then we will apply the electrodes and connect the wires to them, which I'll show you where all those go here in a minute. We will operate the electrocardiograph or the machine, which entails, like I had mentioned, just typing in the patient information and then, pushing the button when you need to. We run the EKG and then we go ahead and check the tracing just to make sure everything is good before we let the provider take a look at it. So electrocardiogram leads. So we work off of a 3-channel, 12 lead machine usually. There is such a thing as a 1-channel, but that's the one you see generally. EMTs have those on their ambulances to just get that one rhythm strip. The 3-channel allows for all the other leads to be recorded. Now here's where it gets a little confusing. It is called a 12 lead because there are 12 pictures. Okay, if you noticed on let me go back to that real quick. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. We don't count the rhythm strip because that's the same as this. So that is a 12 lead, okay? People get super confused though because you only put 10 electrodes on the body. It's 12 leads because it's 12 snapshots, 12 pictures of the heart from those different angles. And that is the electrical activity that is happening between any two electrodes, depending on which direction the picture is being taken from. There are 10 electrodes and lead wires, though, that we place onto the patient. There are 4 limb leads. That's right arm, right leg, left leg. The right leg doesn't record anything. It's there for a ground, okay, like any other electrical thing. And then there are 6 chest leads, and that is V1 through V6. They are abbreviated as V. I will point out, if you have in your office or your office has purchased a lead harness with lead wires that are European in nature, it won't say V, it'll say C. Same difference. And it won't have RALA, RLLL like most have on them to indicate which wire goes where. It'll be NF, RLNF for the limb leads. The colors are the same generally, though, and I'll get to that here in a minute. But the good news is on the harness itself, the large piece in the middle that I was showing you gets held by that arm on the really fancy, nice EKG carts. There's always a picture of what is what. So don't fret. If it's a different kind, you can still get it done. Okay. So here's what, again, standard looks like. Red for the right arm, black for the right leg, yellow for the left arm, and green for the left leg. The way most people will remember this is fire over smoke, sun over grass. Okay. Now there are 2 ways to do this. This is the most common, where you put the arm leads on the lower arm and the leg leads on the lower leg. You can alternatively put the arm leads up on the shoulders and the leg leads on the kind of the groin area if need be. I prefer to do it this way. And where you want to place these limb leads is in what I call the squishy area. So on the forearm, literally like right here on the forearm, where it's squishy, not directly onto the bone. The leg, the same thing, kind of on the inside of the calf where it's squishy. Okay. That is where you place limb leads. And again, make certain that you are looking at their right and their left because it does matter. Okay. Here are your precordials or your chest leads or your V leads. Okay. V1 and V2. Again, these colors are generally the same on almost every harness you get. V1 and V2 go in the 4th intercostal space. So here's your collarbone, 1, 2, 3, 4 spaces down in between the ribs. And V1 goes just to the right of the sternum, and V2 goes just to the left of the sternum. So 4th intercostal space down, just to the right and just to the left of the sternum. Now, when you're first learning how to do these, yes, you may have to take your hand and actually feel for those spaces in between the ribs. Don't push too hard. You don't have to push too hard. But keep in mind, a rib is only about that wide in most people. So it's literally just, a finger width apart. And you just count them down. Once you get really good at it, you generally don't have to do that anymore. Okay. Then what I do and you don't have to do this, but this is what has been easiest for me. I go ahead and apply V4 next because V4 has to be in the fifth intercostal space, mid-clavicular line, meaning if you can look at the clavicle or the collarbone, divide it exactly in half, and just kind of a mental line all the way down to that fifth intercostal space, which is literally just one more down from where you put V1 and V2, and put it right there, you're in the right spot. Now, on a female, this usually will land just under the breast line. On a male, you have to kind of pay attention to the ribs. Okay. Then I do V6 next because V6 also lies in the fifth intercostal space, mid-axilla. So you basically have to like pretend like you're drawing a line from the middle of their armpit down to that fifth intercostal space. Okay. Now, keep in mind, these three have to be in the fifth intercostal space, this one just slightly above it. So it makes kind of like a half smile. I call it a Mona Lisa smile because it's not quite a full smile. It's just kind of smile. So that's the best way to do that. But once I can place this one and this one, literally these two just kind of fall in between. Okay. And you want them fairly evenly spaced out. So one more time, V1, V2, fourth intercostal space to the right and to the left of the sternum. V4, mid-clavicular line, fifth intercostal space. V6, mid-axilla, fifth intercostal space. And then V5 goes in the fifth intercostal space in between 4 and 6, and 3 evenly to the right of V4. Okay, again, highly recommend screenshotting that. Okay, so once we're all hooked up and our tracing is occurring, there's a lot of things that can happen that can cause problems. Okay. So our next job at this point is to basically troubleshoot if needed. Okay. Um, Oftentimes we will see the problems we'll have are called artifacts. And artifacts are basically just issues within the tracing that aren't related to the heart. They're not related to the electrical activity of the heart at all. It's something in how it's hooked up or the machine or something like that. So as a medical assistant, you should be able to identify these, understand what's causing them based on how they look, and know what to do to fix them. So I'm going to go through that with you. Okay, so this is what's called a muscle or somatic tremor. And basically, it just kind of looks like a fuzzy, irregular tracing. It looks like it's, going zzz, okay. This is usually due to either voluntary or involuntary muscle movement on the part of the patient. If they're cold, they could be shivering. If they have, an illness or a condition that causes them to, shake, have tremors like Parkinson's or something like that. Um, Now with most voluntary movement, you can just ask them to hold very still. If they're cold, throw a blanket over them, try to warm them up. Parkinson's, there's not much you can do about that. So what I would recommend and what I've done in the past with patients that can't control the muscle movement, try to get the tracing as quickly as possible in between tremors if you can. Like freeze it or print it. Otherwise, just document that patient's condition so when the provider is looking at it, they understand why it looks like it does. That most of the time, as long as everything else is okay, they should be able to read at least enough of it to know. Wandering baseline is literally a tracing that like wanders either up or down like this. It doesn't go straight across. This is usually due to a loose electrode. Maybe the electrode is dried out. Electrodes do expire, so you have to pay attention to the expiration dates on those. If they're dried out, they're not going to stick well, they're not going to conduct well. It could be uh, the fact that an electrode got disconnected, and you can't see it really because maybe the skin was really oily or there's lotions or creams. In that instance, of course, just take the electrode off, clean the area really good with an alcohol prep, and then try to put a new one on. Or there could just be excessive movement in the chest. Like if they're breathing really heavily, that movement can cause a wandering baseline. So you kind of just check all those things and make sure, that you're good. 60 cycle, or what they call AC interference. And I apologize that these got up on here. um, look like little spiky lines. I always say they look like electricity to me, which I don't know what electricity looks like, but I don't know, maybe like a lightning bolt or something. This is usually due to electrical interference. So there's some type of electrical device maybe in the room, their cell phones on them, something like that, that is causing interference electrically with the machine. It also can be due to dangling lead wires. So if the lead wires are like falling, especially the limb lead wires, because they're longer, if they're dangling off the side of the table, sometimes that can cause this as well. So you just want to check all of that. Interrupted baseline is where you kind of have like a chaotic interruption in the baseline. So see, it's going along just fine, and then this got all crazy. That's usually because the metal tip of the lead wire has detached from the alligator clip for some reason, or you have a frayed or broken cable. So that's why it's always very important to make sure that you're maintaining your equipment well and that you are paying attention, to those things, checking everything out before you use it. Okay, so let's take a quick look. This will be last to just kind of see what normal and abnormal look like. As a point of order here, we as medical assistants do not interpret EKGs. That is for the providers to do. We troubleshoot. We try to make sure that they look normal as they can. But it is not our job to interpret them. However, if you do these enough, you will see these various arrhythmias. So I am going to show them to you primarily just to explain what causes them, so that if you do see something like this, A, it's not artifact, and B, just so you don't go, wow, that's weird. Why is that like that? Okay. So this is what a normal sinus rhythm looks like. NSR, normal sinus rhythm. I wish they were all this beautiful. Okay. And they're not always going to be this big either. Sometimes, if the amplifier in the machine's not amplifying, or there's just not a ton of electrical activity, being put off, these aren't necessarily going to be all this nice, big, tall, spiky like this. Okay. But this is like as close to perfect as you can get. Then you have what's called sinus bradycardia. So everything else is good. We have the PQRST, okay? But look at how far in between there is, the distance between each of these cardiac cycles. That's because this person's heart is going ba-boom, ba-boom, ba-boom. It's bradycardia. It's slow. Okay. Um, this is a heart rate that is under 60 beats per minute, because remember, 60 to 100 is normal for an adult. Under 60 would be known as bradycardia, slow heart rhythm. Unlike tachycardia, which is the opposite. Still, again, we've got PQRST, but there's very little time in between. This person's literally going ba-bum, 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 ba-bum. It's nice and even. There's no problem there. It's just really fast. Okay. So that is tachycardia. That means that's over 100. This is called PAC, or premature atrial contraction, which is just how it sounds. It's when an impulse discharges to the atrium prematurely, like before it's supposed to. So you do have this kind of weird, like you're okay, you're okay. Oh, oh, there's an extra. Okay, you're okay, you're okay, you're okay. It's just got this kind of little extra, not an extra beat necessarily. It's just there's an extra short space there. Okay. Atrial flutter is when just the atria, so just the two top chambers of the heart, are beating very rapidly and kind of fluttering. So you see that here where you never really have any baseline, you never really have a flat line here. So that caught and you've got a dysrhythmia, meaning they're not, we used to call it marching out, right? It's not marching out. There should be the same amount of space between this and this in every single one. And there's not the same amount of space here. There's only 1, 2, 3, and a little bit of a square here where there's 1, 2, 3, 4, almost 5 squares there. Okay. So this is just kind of it's kind of flipping out a little bit. Atrial fibrillation, or AFib, people live with this quite often. This is an irregular beat of the atria, and basically what happens is the atria and the ventricles are out of sync. So normally you should have boom, 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 right? Um, AFib, I can't even do AFib because it's out of sync. It's like boom, 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 boom. It's not in sync. Okay, so you see that very clearly here, but you also see that with the fact that there's no, the depolarization and the repolarization aren't in sync with one another, and that is AFib. Many times people with AFib will end up too with a pacemaker. So just saying. PVCs, or premature ventricular contraction. So we had a PAC, which was when the atria contracts prematurely. Well, this is when the ventricles, the bottom chambers of the heart, contract prematurely. So you end up with kind of like an additional beat and then this weird kind of thing here. Okay. So very kind of out of sorts, and we don't even have an actual, I mean, you got a P wave. Well, no, that's more of a T, and then yeah, it's weird. Just weird. This is ventricular tachycardia, or VTAC. This is faulty electrical signals that cause just a rapid heart rate. Most of the time, there's also what they call sinoventricular tachycardia, or SVT. Most of the time, if this goes on for very long, they generally will have to take extraordinary measures to kind of reset the heart. Sometimes shocking it works, but yeah, so this it's disorganized because there's nothing happening correctly as far as the electrical signals go to cause the normal P wave and QRS and T wave and stuff like that. So you're just kind of chaotic. VFib, or ventricular fibrillation. So I said people can live with AFib. VFib, not so much. So VFib is caused by insufficient blood flow or heart damage or both. And if not addressed immediately, VFib can be fatal. It's not a sustainable rhythm. So this is something that would have to be addressed immediately. Immediately. So yes, if you were to see something like this on an EKG that you were doing in the office, if the patient came in with symptoms, this would be something you'd want to have the doctor come and look at like immediately. Okay. All right. Well, thank you so much for watching. And I will see you next time. Hope you have a wonderful day, and we'll talk to you soon. Take care.